Hi, everybody. So this is your lecture on the GI system. We're going to talk about several different GI disorders. So we're going to get started with this. Let me share my screen with you. Okay, so we're going to talk about several different GI diseases and how nutrition affects each of these. So we're going to get going with that. It is a lengthy slide presentation, so just bear with me, but lots of good information for you. All right, so nutritional therapy. Um, there's lots of different things going on with that, but I'm going to have you cover that on your own as far as the variations in the diets, because this slide presentation is longer. There's no need for me to talk through each of those. Um, these are some GI terms that you need to know what the terms are and then the differences between them. We'll talk about many of these over the course of this lecture. Be sure you're familiar with the various types of diets, the differences between them. Each slide has some of the important highlights for each of these. But again, we'll talk further throughout the lecture with these. Yeah, high fiber diet, low fiber diet, low residue, and then FODMAP. FODMAP is one of those weird acronyms, and it's basically telling you what foods to avoid in a short version of all those really long words. But it's good to know what it means, but just at least understand the point of it. All right, so with our GI disorders that we're going to talk about, this is covering upper and lower GI disorders. So we're going to start with the upper. So nausea and vomiting. With nausea and vomiting, this may be related to a number of causes. So determining the cause can help in the treatment. The short-term concern is fluid and electrolyte balance. IV supplementation can assist in keeping the patient hydrated until they're able to maintain oral intake. Intractable vomiting is a term used for someone with prolonged periods of vomiting. Until the vomiting subsides, food should be withheld, and then when able to resume oral intake, the diet should be started with clear liquids and progress from there to a regular diet. Some other tips, foods should be served room temperature or cold because hot foods can contribute to the nausea. Avoid fatty and spicy foods, and then be sure to provide or encourage good oral hygiene and offer them ice chips. Anorexia is a symptom for many conditions, but also is a side effect for certain medications. The aim of nutritional therapy is to stimulate the appetite to maintain adequate nutritional intake. Some things that may help are to make sure that food looks appealing and seasoned according to the individual's preferences. If the person has a limited ability to taste, then use things that will enhance this. So things that are tart, like orange juice, vinegar, lemon juice, or stronger flavors. Maybe use basil, oregano, mint. And then having small, frequent meals and limiting fatty foods can help. Withholding beverages at mealtime to allow for more nutrient-dense food intake as opposed to the liquid, but offer liquids between meals to make sure that you're supplementing not only the fluid aspect, but also needed calories and protein if they're not eating enough at mealtime. Gastritis. This is an irritation and inflammation of the gastric mucosa. This can be acute or chronic. Treatment is based on the symptoms and the severity. There are, of course, foods that should be avoided to reduce irritation from excess gastric acidity. GERD is gastroesophageal reflux disease. It's caused by an abnormal reflux of the gastric contents into the esophagus related to an abnormal relaxation of the lower esophageal sphincter. Some of the symptoms include complaints of a lump in their throat, maybe indigestion, heartburn, regurgitation feeling. The pain may become worse after lying down or wearing tight clothing after eating. This often occurs after eating a large or fatty meal. If it's left untreated, chronic GERD can lead to reflux esophagitis, dysphagia, which is the difficulty swallowing, adenocarcinoma, esophageal ulcers, and bleeding. Treatment for GERD includes lifestyle modification of nutrition therapy. Drug therapy might be used, and then potentially surgical intervention. Eliminating anything that can contribute to the GERD can be beneficial in reducing symptoms, as well as elevating the head of the bed, lying on the left side when sleeping, and then weight loss. This is just a picture of the irritation that GERD causes to the stomach lining. Peptic ulcer disease. Peptic ulcers are found either in the stomach, which accounts for about 15% of ulcers, or in the duodenum, which accounts for about 85% of ulcers. H. pylori, which is Helicobacter pylori, is an infection found in about 70% of gastric ulcers and 92% of duodenal ulcers. H. pylori secretes an enzyme that depletes the gastric mucus, making the mucosal layer more susceptible to erosion. Antibiotics can usually destroy this bacteria and cure the ulcer. NSAIDs, so your ibuprofen, your Advil, is the second leading cause for these ulcers. Some dietary modifications can help in managing the symptoms associated with peptic ulcer disease, such as avoiding alcohol, chocolate, coffee, pepper, and then encouraging a high fiber diet and avoiding eating within 2 hours of bedtime. This is a picture that shows a much more severe irritation of the gastric mucosa with what appears to be an ulcerated lesion or erosion through the intact gastric mucosa. This could be a result of H. pylori, but it would obviously need to be tested to know for sure. It's easy to also see the redness of the tissue around the obvious eroded area. Dumping syndrome. So nutritional complications of gastric surgeries, which we will talk about later on in this lecture, depend on the extent of the gastric resection and the type of reconstruction performed. A common complication of gastrectomy and gastric bypass is dumping syndrome, which is a group of symptoms caused by rapid emptying of stomach content into the intestine. With the rapid shifting of fluids and the volume of circulating blood decreasing, the patient may experience weakness, dizziness, rapid heartbeat. These symptoms can occur within 10 to 20 minutes of eating and characterize the early dumping syndrome. Intermediate dumping can occur within 20 to 30 minutes and might be accompanied by abdominal pain, cramping, diarrhea. And then late dumping can occur within 1 to 2 hours. Rapid absorption of carbohydrates causes a sudden glucose spike, causing the body to overcompensate by secreting higher doses of insulin. This causes glucose levels to drop rapidly, and the patient develops symptoms of hypoglycemia, so shaking, sweating, weakness, confusion, those things. Patients are at risk for malabsorption, maldigestion, and decreased oral intake. With dumping syndrome, the excretion of calories and nutrients produces weight loss and increases the risk of malnutrition. Some ways to help control and prevent these symptoms include eating small, frequent meals containing protein, fat, and complex carbohydrates, encouraging liquids between meals and not with meals, and consuming functional fibers such as pectin or guar gum may be used to delay gastric emptying and treat diarrhea. Avoiding simple sugars and sugar alcohols, restricting lactose due to high risk of lactose intolerance, and then patients may be encouraged to lie down after eating to delay gastric emptying. Now let's shift to the lower GI tract disorders. Let's start with compensation. Excuse me, constipation. Constipation, which is defined as the frequent or infrequent passage of stools that are hard or dry. It can be a result of a number of reasons, including inadequate fluid or fiber intake, lack of activity in metabolic or endocrine disorders, or bowel abnormalities. Additionally, medications can cause constipation, specifically your narcotics, iron supplements. Treating the underlying cause is the best plan of care. For most patients, increasing fiber and fluid intake is sufficient to relieve and prevent constipation. You can use soluble fibers such as psyllium or metamucil, which absorb water, helping to make the stool softer and bulkier to pass more easily. Remember that high fiber diets consist of fruits, vegetables, beans. If someone isn't getting the adequate amount of fiber daily through their food, they can take a supplement. Women should have about 25 grams a day, and men about 38 grams a day. Most people consume only about half of what they really need. Ensuring adequate fluid intake is important, and if someone increases their fiber intake without increasing their fluids, it can actually lead to increased constipation. And then, as always, exercise is great for everything. It's also important and helps to stimulate bowel activity. Switching to diarrhea. Diarrhea is characterized as more than 3 bowel movements in a day, consisting of large amounts of liquid or semi-soft stools. Because of the short amount of time in the colon, water, sodium, and potassium are not absorbed and can lead to dehydration. Also, electrolyte imbalance, acid-base imbalances, and metabolic acidosis. Chronic diarrhea can lead to malnutrition. There's osmotic diarrhea, which occurs with an increase of particles in the intestine, causing water to be pulled in to dilute the concentration. This could be from a number of causes, including lactose intolerance, excessive sorbitol or fructose intake, dumping syndrome, if somebody's on tube feedings, and then some laxatives as well. Secretory diarrhea is related to an excessive secretion of fluids and electrolytes into the intestines. Certain infections, medications, GI disorders like Crohn's or celiac can also be causes. The primary nutritional concern with diarrhea is the fluid and electrolyte balance. 24 to 48 hours of mild diarrhea requires liberal fluid replacement. So you want like your Pedialytes and eating foods higher in potassium. If the cause of the diarrhea is suspected to be lactose intolerance or antibiotics, then probiotics are recommended. If someone has intractable diarrhea, this means they have extensive lengths of time, could be weeks, with diarrhea. They may need to have a complete bowel rest, meaning nothing by mouth, and have an IV infusion of TPN, total parenteral nutrition, to be able to give that bowel a rest, but still get the nutrients that they need. Malabsorption occurs secondary to nutrient maldigestion or from alterations to the absorptive surface of the intestinal mucosa. Symptoms depend on the disorder that's causing it. Nutrition therapy is individualized based on the symptoms, the condition, and the complications the person is having. So we're going to talk about lactose intolerance first. Lactose intolerance occurs when the levels of lactase, which is the enzyme that splits lactose into its component simple sugars, glucose and galactose. The lactase levels are deficient or absent. Not having enough lactase and lactose digestion is impaired. This can lead to osmotic diarrhea. The amount of lactose is individualized. Some people can tolerate more than others can. Typically, smaller amounts of lactose containing foods are tolerated better. Lactose enzymes are an alternative to assist with the intolerance. Inflammatory bowel disease refers to two chronic GI diseases. You have Crohn's disease and you have ulcerative colitis. These two disorders share common symptoms and treatments and are believed to be caused by an abnormal immune response to a complex interaction between environmental and genetic factors. With both Crohn's and ulcerative colitis, patients will experience periods of exacerbation and remission. Nutrition needs depends on the presence and severity of the symptoms and complications. Crohn's is more likely to cause nutritional complications. In general, dietary recommendations include avoiding lactose, consuming low fiber foods, and increasing protein and calories. This shows a bowel of a patient with Crohn's disease. You can see all of the lesions there. And then in contrast between the larger, more obvious lesions of Crohn's, this is ulcerative colitis, which has more subtle lesions, yet obvious inflammation is present. Celiac disease. This is a genetic autoimmune disorder characterized by chronic inflammation of the proximal small intestinal mucosa related to a permanent intolerance to certain proteins, gluten, found in wheat, barley, and rye. When ingested, these proteins trigger an immune response that damages the mucosa of the small intestine. Symptoms and their severity vary patient to patient. There are long-term complications that can occur with untreated celiac disease, such as certain cancers. The only scientifically proven treatment is to completely and permanently eliminate gluten from the diet. This is very challenging. Pure oats are gluten-free, allowing patients to have some grains in their diet. However, there is a concern with contamination of oats with gluten. Therefore, they're really not recommended for these patients to eat. A gluten-free diet is a lifestyle change and can be extremely challenging to maintain. It is very restrictive. The ability to read food labels is critical. It is difficult to eat out to ensure food choices are really gluten-free. Rice, corn, and potato flour are staples in this diet. It's important that patients understand that compliance with these dietary needs is important because even small amounts can have harmful effects. Short bowel syndrome. This occurs when the bowel is surgically shortened to the extent that the remaining bowel is unable to absorb adequate levels of nutrients to meet the individual's needs. This could be due to Crohn's, traumatic injuries, or tumors. Nutrition complications depends on the location and extent of the resection. Patients may require long-term TPN for nutrition and hydration, and then can progress back to an oral diet depending on the patient's specific situation. Once someone is able to start oral nutrition, small and frequent meals throughout the day are recommended. Simple sugars are avoided to limit the osmolar load to the intestine and osmotic diarrhea. Lactose intolerance may be an issue. Steatorrhea, that's one of those terms in the beginning. This is excess fat in the stool, can be a problem, so fat intake is restricted. Complex carbohydrates are encouraged because bacteria in the colon ferment them into short chain fatty acids, which is an important source of energy. Irritable bowel syndrome, also known as IBS, is one of the most frequently diagnosed digestive disorders, and it affects as many as 20% of adults in the United States. Although it is commonly categorized as a motility disorder, there are likely many contributing factors, including genetics, environmental factors, gut flora, or nervous system alterations, and then psychosocial stressors that can be contributing as well. There are various nutritional treatments. Probiotics such as yogurt has been shown to improve symptoms of IBS by improving the intestinal flora. Additionally, there's evidence that guar gum, which is a soluble, non-gelling fiber that acts as a prebiotic to increase that good gut flora. When that is used daily, it can reduce symptoms and overall um, improve the quality of life. Bran is also beneficial in improving symptoms, but patients who used it preferred the guar gum. Ileostomies and colostomies. These are performed after part or all of the colon, anus, and rectum are removed, usually for treatment of severe inflammatory bowel disease, intestinal lesions, obstructions, or colon cancer. Potential problems with these patients, nutrition occurs because large amounts of fluid, sodium, and potassium are normally absorbed in the colon. The smaller the length of the remaining colon, the greater the potential for nutritional problems. For this reason, ileostomies create more problems than colostomies. Ileostomies not only have fluid and electrolyte losses, but a decreased absorption of fat, bile acid, and vitamin B12. Effluent is the term for the discharge that comes out of these sites. With an ileostomy, the effluent is liquidy. From a colostomy, the effluent varies from being liquidy to formed stool, and this is all dependent upon the amount of colon that remains. The goals for patients with either of these is to minimize symptoms and replenish the losses. Initially, clear liquids are given with minimal simple sugars to reduce the risk of osmotic diarrhea. Once clear liquids are tolerated, the diet is slowly advanced based on patient tolerance. Extra protein and calories are needed to promote healing. It is common for patients to be fearful of eating due to the entire experience. Most patients should be back to a regular diet within 6 to 8 weeks following their surgery. Patients need to have an increased fluid intake of 8 to 10 cups a day to replenish their fluid losses, but also to maintain an adequate urine output and minimize kidney complications. This shows the location of ileostomy. Again, small intestine, and it's on the right side is where your stoma would be. Colostomy, large intestine, and on the left side. All right, diverticulosis and diverticulitis. Diverticula are caused by increased pressure within the intestinal lumen. Usually, they're asymptomatic. Diverticulosis is when someone has diverticula. Diverticulitis occurs when those diverticula become inflamed, possibly from trapped stool or bacteria. Potential complications include occult blood loss, acute rectal bleeding, which can both lead to iron deficiency anemia. Abscesses or bowel perforation can lead to peritonitis. Fistula formation causing bowel obstruction, and bacterial overgrowth that leads to vitamin B12 malabsorption. And I'm just going to fix this real quick because I would assume you all know what it means, but I like to make sure. Okay. And then remember, this is just a picture of the colon to remind you where the sigmoid colon is, which is where diverticula are typically found. And then this shows diverticula on the right here. Um, and then most likely on the left side here, the two upper left pictures are diverticulitis. And then it looks down here as though there are some perforations with the small holes that you can see in this picture. High fiber diets are recommended to prevent and improve symptoms of diverticulosis. Preventing diverticulitis by producing stool that is more easily passed decreases the pressure in the colon and reduces time the stool sits in the colon. Once someone has a diagnosis of diverticulosis, maintaining a high fiber diet will not make the diverticula disappear. These patients are instructed to avoid nuts, seeds, popcorn, so that they do not become trapped in the diverticula and cause diverticulitis. Someone with diverticulitis is instructed to remain in PO until bleeding and diarrhea subside. Once oral intake is resumed, again, you start with clear liquids and initially gradually progress to a low fiber diet until the inflammation and bleeding are no longer at risk. High fiber diets are then recommended unless diverticulitis symptoms recur. And then educating the patient on the importance and the rationale of high fiber is important to manage diverticulosis and reduce the risk of the recurrence of diverticulitis. The liver, pancreas, and gallbladder are known as accessory organs to the GI tract. They are vital to the digestion of macronutrients. The gallbladder's role in digestion is to store and release bile, which prepares fat for digestion. Bile, which is made in the liver, consists of cholesterol, bile salts, bile pigments, and water. As it is held in the gallbladder, water is slowly removed from the bile, making it more concentrated and increasing the likelihood that solids will form. These solids are known as gallstones. If the gallbladder is not completely emptying, this can contribute to gallstone formation. Many people develop symptoms following a fatty meal. Someone who has gallstones is diagnosed with cholelithiasis. Most people with cholelithiasis are asymptomatic, but some experience symptoms that mimic a heart attack, so they might have chest pain, shoulder pain. There are generally no diet modifications needed for people with asymptomatic gallstones. If the gallstones end up obstructing the cystic duct, this can lead to cholecystitis, which is inflammation of the gallbladder due to the irritation. These patients can experience abdominal pain, nausea, vomiting, jaundice, fever, fat intolerance, and flatulence. Symptomatic patients are instructed to limit their fat intake, and many can benefit from decreasing their intake of foods that are spicy, high fiber, and gas producing. Also, if someone is symptomatic with cholelithiasis, surgical removal, which is a cholecystectomy, might be necessary. The pancreas. So the pancreas is responsible for secreting enzymes needed to digest dietary carbohydrates, proteins, and fat. These enzymes remain inactive in the pancreas until they are needed. Inflammation of the pancreas causes digestive enzymes to be retained and converted to their active form, so they literally begin to digest the pancreas. The pancreas is also responsible for the production of insulin, so people with pancreatitis may also develop hyperglycemia as a result of insufficient insulin secretion. Up to 85% of acute pancreatitis cases are a result of either alcohol abuse or gallstones. Mild acute cases typically resolve in a few days, but moderate to severe cases usually require hospitalization with treatment, and patients need to be NPO. Acute cases that either do not resolve or recur frequently, those can lead to chronic pancreatitis. 70% of these cases are a result of alcohol abuse, and 20% are idiopathic, so we don't really know what the cause is. Malabsorption isn't typically a problem until enzyme secretion is less than 10% of the normal, because the pancreas normally secretes enzymes greater than what the body actually needs. Steatorrhea occurs late in the disease. Patients may develop symptoms of diabetes. Acute pancreatitis is treated by reducing pancreatic enzymes. Patients requiring hospitalization are given pain meds, IV fluids, and then again, they're kept NPO. Once patients able to resume oral intake, advancing from clear liquids to a low-fat, high-protein diet with smaller frequent meals may be best tolerated. If patients have moderate or severe cases, an NG tube may even be needed. If insulin secretion is impaired, a diabetic diet may be needed to control that hyperglycemia. And then supplementing with antioxidants may help to reduce the pancreatic inflammation and pain. And then taking pancreatic enzymes is crucial for maximum effectiveness. Liver disease. So the liver is an active organ highly involved in the metabolism of all nutrients. After absorption, almost all nutrients are transported to the liver for processing before being distributed out to the tissues. It is responsible for synthesizing plasma proteins, blood clotting factors, and non-essential amino acids, as well as forming urea from the nitrogenous waste of protein. Additionally, it has many important roles in metabolism. Liver damage can have profound and devastating effects depending on the severity. Hepatitis is an inflammation of the liver that can be caused by a number of things, including viral infections, alcohol abuse, and certain hepatotoxic chemicals. Sometimes acute hepatitis progresses to chronic hepatitis, which can then lead to cirrhosis, liver cancer, and liver failure. It is common for these patients to have glucose intolerance. These patients can also have many other associated complications, and the cirrhosis can progress to hepatic encephalopathy, which affects the central nervous system. And then patients have symptoms of irritability, short-term memory loss, or they could have hepatic coma, where they have unconsciousness as a result of the severity of the liver disease. Nutritional therapy includes avoiding permanent liver damage, minimizing the effects, promoting liver cell regeneration, restoring optimal nutrition status, alleviating symptoms, and avoiding complications. For patients with hepatitis, maintaining an adequate diet may be challenging, but a balanced diet with supplements between meals can also be beneficial. Malnutrition is common among cirrhosis patients. These patients can benefit from increasing caloric and protein intake while limiting their fat and sodium. Carbohydrates are not restricted unless the patient is diabetic. And then liver transplant might be a viable option for patients with severe and irreversible liver disease. All right, bear with me, we're getting close to being done. So let's talk about bariatric surgeries. Bariatric surgery is the most effective treatment for severe obesity, which is defined as a BMI greater than or equal to 40. It is also appropriate for patients with a BMI above 35 that have major comorbidities. Studies have shown it is the most effective treatment for patients with diabetes, hypertension, obstructive sleep apnea, and high cholesterol. Intensive nutritional counseling is critical to help optimize the effectiveness of the surgery. Surgical procedures work for obesity by restricting the stomach's capacity, creating malabsorption of nutrients and calories, or a combination of both. There are three types of bariatric surgeries, and we're going to talk about each of those. The first is laparoscopic adjustable gastric banding. With this approach, an inflatable band is encircled around the upper part of the stomach and buckled. This restricts the stomach's capacity by creating a small pouch that has only about a 15 to 30 milliliter capacity. With this surgery, patients must understand the importance of eating small meals, eating slowly, and chewing their food thoroughly, with their diet advancing from liquid to puree and then to soft foods over time. This surgery has the lowest mortality rate of all bariatric surgeries, but also has the smallest weight loss with frequent band adjustments. And this is just a picture to show you what that looks like with the band. And they can adjust the band as time goes on. All right, Roux-en-Y gastric bypass. Gastric bypass combines gastric restriction to limit food intake with the construction of bypasses of the duodenum and the first portion of the jejunum, which creates malabsorption of calories and nutrients. Rapid emptying of the contents within the stomach pouch into the small intestine may produce dumping syndrome. So remember, that is characterized by symptoms of nausea, flushing, lightheadedness, dizziness, diarrhea, abdominal cramping. The major complication with this procedure is anastomotic leak. So leaking where the surgical incision is located. Remember the anastomosis. Iron, calcium, and vitamin B12 deficiencies may occur. Patients tend to lose more weight over a 5-year time frame with this surgery than they do with the gastric banding. The diet is comparable to gastric banding in that the patient needs to consume small quantities of sugar-free liquids. Patients should be able to advance to full liquids within a week and then progress from there to puree and then regular within 5 to 6 weeks after surgery. Unlike the gastric banding surgery, nutrient deficiencies and dumping syndrome are specifically a problem with the surgery. Long term, patients are more successful in weight loss maintenance when considerable physical activity is included with a balanced diet. And this shows that gastric bypass. With a sleeve gastrectomy, the longitudinal portion of the stomach is removed to create that sleeve effect. So smaller stomach, smaller capacity, with complications and nutrient needs and deficiencies similar to those for the gastric bypass surgery. And this just shows what a sleeve gastrectomy looks like and the difference in the stomach size pre and post surgery. So I know this was a lot of information, so thank you so much for sticking with me through this. Be sure you understand the differences in the disorders and how the nutrition is impactful with each. Um, Read your chapters, and thank you, and I hope you have an awesome day.